Hello everyone, welcome back to class. Previously, we learned about pulmonary ventilation. We know that respiratory rehabilitation is highly significant for improving patients' quality of life. Before initiating rehabilitation therapy, the therapist must assess the patient's pulmonary function status in order to formulate a reasonable and feasible rehabilitation plan. Today, we will learn how to assess pulmonary ventilation function. Before evaluating pulmonary ventilation, let's first recall the process of breathing movements. Respiratory muscle movement causes changes in thoracic volume through the coupling action of the pleura. It drives the expansion and contraction of the lungs. This process is influenced by various factors including the respiratory muscles, thoracic cage, pleura, the lungs themselves, and airway resistance. Respiratory muscle paralysis and elastic changes in the lungs and thoracic cage can all lead to restricted lung expansion, resulting in restrictive ventilatory insufficiency, whereas bronchospasm, foreign bodies in the airway, or external tumor compression causing reduced airway diameter or respiratory tract obstruction can lead to obstructive ventilatory insufficiency. Therefore, the assessment of a patient's pulmonary ventilation function must not only identify the presence and degree of pulmonary ventilation dysfunction, but also determine the type of reduced pulmonary ventilation function. This is to formulate a targeted rehabilitation plan. The lungs, as the site of gas exchange, measuring their capacity to hold gas is the most direct indicator for evaluating pulmonary ventilation function. During breathing movements, the volumes of inhaled and exhaled gas can be measured and recorded using a spirometer. Let's look at what these indicators are. Lung volume refers to the amount of gas contained within the lungs. It is the total capacity of the respiratory tract and alveoli, reflecting the space for external respiration. During respiration, as the respiratory muscles move and the thoracic cage expands and contracts, lung volume changes accordingly. Lung volume has static anatomical significance and also provides the basis for dynamic respiratory function. There are four basic lung volumes, namely tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume, and four basic lung capacities, namely inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Except for residual volume and total lung capacity, the other indicators can be directly measured by a spirometer. First, let's look at the four basic lung volumes. Under resting conditions, the gas we inhale and exhale with each breath is called the tidal volume, named because breathing alternates like the ebb and flow of the tide. The normal tidal volume for adults during quiet breathing is 400 to 600 milliliters. During exercise, tidal volume increases on top of normal breathing at the end of inspiration and expiration respectively, continuing to inhale and exhale maximally. These two portions of gas are called the inspiratory reserve volume and expiratory reserve volume. The normal inspiratory reserve volume for adults is 1,500 to 2,000 milliliters, and the expiratory reserve volume is 900 to 1,200 milliliters. The inspiratory reserve volume reflects the inspiratory reserve, while the expiratory reserve volume reflects the expiratory reserve. After we exhale maximally, we cannot exhale all the gas from the lungs. This remaining gas is called the residual volume. The normal residual volume for adults is 1,000 to 1,500 milliliters. The reason we cannot exhale all the gas from the lungs is that at the end of maximal expiration, the bronchioles, particularly the respiratory bronchioles, close. Additionally, the outward elastic recoil force of the thoracic cage also prevents the lungs from recoiling to their natural volume. The presence of residual volume prevents alveolar collapse at low lung volumes. If alveoli collapse, a very high transpulmonary pressure is required to re-expand them. Patients with bronchial asthma and emphysema have increased residual volume due to difficulty exhaling. Here the teacher needs to explain this sentence specifically. The outward elastic recoil force of the thoracic cage also prevents the lungs from recoiling to their natural volume. Looking from the side view of the body, we can see that the ribs slope downward from back to front. At the end of our quiet expiration, the thoracic cage is in its natural position. At this point, the elastic recoil force of the thoracic cage is 0. But at the end of forced expiration, when the thoracic cage is smaller than its natural position, the elastic recoil force of the thoracic cage is outward. If we think of the thoracic cage as a spring, at the end of quiet expiration, this thoracic cage spring is at its natural position, neither stretched nor compressed. Similarly, if we think of the lung as a spring, the natural position of this spring only exists before you utter your first cry. When the first cry opens the lungs remain in a stretched state throughout the entire breathing process. So the latter part of the sentence says the lungs cannot recoil to their natural volume, only when the pleural coupling is lost, such as in pneumothorax, and the lungs are detached from the pole of the thoracic cage. Will they return to their natural volume due to their own recoil force? After looking at the 4 basic lung volumes, let's look at the 4 basic lung capacities. A lung capacity is the combination of 2 or more lung volumes. If the 4 basic volumes are added together, the resulting capacity is the total lung capacity, which is the total amount of gas contained in the lungs after maximal inspiration. It is 5,000 to 6,000 milliliters for normal adult males, and 3,500 to 4,500 milliliters for females. Restrictive diseases of the lungs or chest wall, such as pulmonary infiltrates, atelectasis, pulmonary interstitial fibrosis, and neuromuscular diseases, can all lead to a decreased total lung capacity. Obstructive diseases such as bronchial asthma, emphysema, etc., can cause an increased total lung capacity. A change of more than 20% is usually considered abnormal. The amount of gas that can be inhaled from the end of a quiet expiration is the inspiratory capacity. It is the sum of tidal volume and inspiratory reserve volume, and is one of the indicators measuring maximum ventilatory potential. When the thoracic cage, pleura, lung tissue, or respiratory muscles are affected by disease, the inspiratory capacity can decrease, reducing the maximum ventilatory potential. Subtracting the inspiratory capacity from the total lung capacity gives the functional residual capacity, which is the volume of gas remaining in the lungs at the end of a quiet expiration. Functional residual capacity equals the sum of residual volume and expiratory reserve volume. It is about 2,500 milliliters in normal adults. Patients with emphysema have an increased functional residual capacity, while patients with parenchymal lung diseases have a decreased functional residual capacity. The physiological significance of functional residual capacity is to buffer the fluctuations in alveolar oxygen and carbon dioxide partial pressures during breathing. Due to the dilution effect of the functional residual capacity, the partial pressures of oxygen and carbon dioxide in the alveoli and arterial blood do not fluctuate drastically with each breath, which is beneficial for gas exchange. Part of the total lung capacity is the unexhalable residual volume, so it cannot be measured directly. Setting this part aside, we have the familiar vital capacity, which is often tested in routine physical examinations. During the test, the doctor will tell you, take a deep breath in, then blow out slowly, trying to exhale all the gas through your mouth. This maximum volume of gas that can be exhaled from the lungs after a maximal inspiration is called the vital capacity. Vital capacity is the sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. Vital capacity has considerable individual variation, related to factors such as body size, sex, age, posture, and respiratory muscle strength. The average vital capacity for normal adult males is about 3,500 milliliters, and for females, about 2,500 milliliters. The method for measuring vital capacity is simple, has good reproducibility, can reflect the maximum capacity for a single ventilation, and is a commonly used indicator in pulmonary function testing. However, because measuring vital capacity does not limit the expiration time, in some patients with reduced lung elasticity or narrowed airways, even though ventilation function is impaired, if the expiration time is prolonged, the measured vital capacity may still be normal. Therefore, vital capacity may not adequately reflect changes in lung elasticity or airway patency, meaning it cannot fully reflect the status of ventilatory function. Hence, a time limit is added during the measurement of vital capacity to better reflect pulmonary ventilation function. This time-limited vital capacity is called forced vital capacity, abbreviated as FVC, which is the maximum volume of gas that can be exhaled as forcefully and quickly as possible after a maximal inspiration. Normally, FVC is slightly less than the vital capacity measured without a time limit. During the measurement of FVC, the volume of gas exhaled in each time period is the forced expiratory volume, FEV. Typically, the volumes exhaled at the end of the first, second, and third seconds are recorded. But to eliminate the influence of the background lung volume, it is usually expressed as the percentage of FEV to FVC. The normal FEV1/FVC, FEV2/FVC, and FEV3/FVC are approximately 83%, 96%, and 99% respectively. Among these, the first-second ratio, FEV1/FVC, has the greatest clinical value. It is highly significant for clinically differentiating between obstructive and restrictive lung diseases. In patients with obstructive lung diseases like asthma, the decrease in FEV1 is more pronounced than the decrease in FVC. Thus, the FEV1/FVC ratio is reduced. It often takes a longer time to exhale the volume equivalent to the FVC. I believe you have also experienced in daily life that after exercise, not only does the depth of breathing increase, what we call breathing deeply, but the breathing rate also increases. Therefore, measuring lung capacity alone is insufficient to reflect pulmonary ventilation function. The respiratory rate must be added. The product of tidal volume and respiratory frequency equals the pulmonary ventilation volume, reflecting the total volume of gas inhaled or exhaled per minute during quiet breathing in normal adults. With a tidal volume of 500 milliliters, and a respiratory frequency of 12 to 18 breaths per minute, the pulmonary ventilation volume is 6 to 9 liters per minute. Pulmonary ventilation volume varies with sex, age, body size, and activity level. Generally, during labor or exercise, pulmonary ventilation increases. To facilitate comparison between different individuals, pulmonary ventilation should be measured under basal conditions. Furthermore, during maximal deep and rapid breathing, the maximum volume of gas that can be inhaled or exhaled per minute is called the maximal voluntary ventilation, MVV. MVV reflects the ventilation volume achievable by fully utilizing all ventilatory capacity per unit time, and is one of the physiological indicators used to estimate a person's capacity for maximal exercise. During measurement, usually only the deepest and fastest volume exhaled or inhaled over 10 or 15 seconds is measured, which is then converted to the maximum ventilation per minute. The maximum ventilation can generally reach 150 L, which is 25 times the pulmonary ventilation during quiet breathing. Rehabilitation link. In rehabilitation therapy, commonly used methods for respiratory function assessment include taking a medical history, physical examination, inquiring about the patient's subjective feelings, Instrument-based measurements and tests, data obtained from different perspectives complement and integrate with each other. Only then can a comprehensive evaluation of pulmonary function be obtained. Now, can you understand these reports?